The purpose of this podcast is simple. We want you to get to know your doctor before meeting them in person, because you're making a life-changing decision and time is scarce. The more you can learn about who your doctor is before you meet them, the better that first meeting will be. There's no substitute for an in-person appointment, but we hope this comes close. I'm your host, Eva Shea, and you're listening to Meet the Doctor. Well, today on Meet the Doctor, my guest is Matt Nykiel, not Nykiel.
That's right.
Who is a plastic surgeon in Newport Beach, formerly the Inland Empire.
We still have an office in the Inland Empire.
Good.
Yeah, so we have two offices. So.
Yeah, that's great. How often do you go back and forth?
Usually we split the week, so I'll spend about two to 3 days in one location one week, and then 2 to 3 days at the other week. So usually even split.
What do you do while you're driving?
I listen to podcasts.
Oh, yeah? What do you like?
So I love doing informational podcasts. I don't know kind of what everybody else is into, but more so in the mornings. I find in the afternoons, I don't have, in the afternoons, on the drive home, I just want to listen to some music, right? But in the morning, I just feel like you're geared
Learning
up.
time.
Yeah, you're right. And you want, so it kind of just depends on what the topic is, right? So any type of learning. I mean, sometimes it's topics as far as house repair.
Yeah.
Sometimes it's, like we were talking about, I have 2 kids, so sometimes it's parenting. Yeah, it depends on what's going on in your life. But honestly, podcast to me in the morning, great.
Yeah.
Sometimes the Real Self podcast, obviously.
Oh, yeah, that old thing?
Yeah.
Right. Amazing how many people still listen to that, and they haven't put an episode out since I left.
That's right.
Years.
That's right.
So tell us a little bit about yourself, as if patients are listening to this, because that's really the purpose.
So my name is Dr. Matthew Nykiel. I'm a board-certified plastic surgeon. I'm located in Southern California. We have 2 offices, Newport Beach and in Upland, California. Our specializations are in body contouring. So I would say the majority of my practice is liposuction contouring, whether that be high definition or soft definition or liposculpting, fat transfers, typically to the buttocks, and then tummy tucks and breast augmentations. I think make up the bulk of my practice.
Since fat seems to be the sort of hot topic of the day.
Yes.
Are you using fat for all of these things, including breast augmentation?
So I don't really like fat transfers for breast augmentation themselves. I think we do it in the reconstructive side. I think it's an option on the reconstructive side, but I think there's some limitations to fat transfers to the breast that aren't as big of a deal on the reconstructive side as they are on a completely elective cosmetic side. And I think the first and foremost is typically when we're doing reconstruction, it's because someone had either a portion of their breast or their entire breast removed. And so I think while we're always striving to get the best result possible, I think that when you're comparing a breast that had either a portion or the entire breast removed, I think a fat transferred breast looks better than having no breast. But I think from an elective sort of cosmetic standpoint, I just think implants give typically a better look. I think that for most people, what they're thinking of when they want an augmented breast, they have the idea of what an implant does, and that's not typically what a fat transfer of the breast does. I think if you're a young individual, 20, 21, 22, I think you have to think about breast cancer screening when you get older. And they've done studies, and I know, and the studies are out there, and the studies basically say that digital MRI mammograms combined with biopsies do an effective job at sort of screening the breast for breast cancers. But I think that if you're 20, that's a long way to pigeonhole yourself, and you don't know what's coming down your life in 10, 20, 30 years. I don't know. And so my sort of feelings have shifted on that. I get 20, 21, 22-year-olds that come in and say, I'd like fat transfer of the breast. I say, I really would encourage you to research this more. I think you've got to take a step back. You've got to think about what's going to happen 20, 30 years down the road. And I don't like it for primary augmentations.
Tell me more about this, because a 20-year-old who just wants bigger breasts, you don't think they should have fat in there at that age?
I think that, so if we think about this on a high level sort of topic, and my opinions about this have changed over time. And I think, that's sort of the part of medicine, and there'll be studies and data and things that'll come out. So when we fat transfer the breast, we're essentially creating scars, and we're placing little pockets of fat. And sometimes those fat can get hard. Sometimes they can calcify. Sometimes they can look kind of scar tissue. On a standard mammogram.
Oh, I see what you're saying.
On a standard mammogram, they cannot tell the difference between is that a cancerous lump is that fat transfer. Now, there's other types of mammograms, MRI mammograms, and they've shown in some studies that the MRI mammograms can
tell the difference.
So that means that for the rest of your life, you're going to have to find an MRI mammogram. Now, that may not be a big deal if you live in a very populated urban area, but if you're living in a rural area, that may be a huge deal. And you may be, even with that digital MRI mammogram, they may say, yeah, we're not totally sure, we need to biopsy these spots. And that may be your life. Again, is that the end of the world? No, it isn't. But is it something that I think you should think about? Yeah, it is. And to me, I think when you compare that, at least with all current breast implant literature, put an implant in, let's say you don't like it, you take the implant out.
Right.
We can't do that. And once the fat transfer has been done, once we've made that, that's it. I just don't think that that's a great option for a healthy 20-year-old. Now, again, studies may come out, my opinions may change. That's just sort of where I sit right now on the thoughts of it.
Oh, I want to throw an analogy at you.
Yeah.
When I was 20, I was in grad school.
Yeah.
And the people I was around in grad school who were in their 50s, because they were all musicians, did not take care of their teeth when they were 20.
Yeah.
And so I could see what was happening to them in their 50s, that they were needing $20,000, $30,000, $40,000, $50,000 in dental work because of things they had done when they were much younger.
Yeah.
That stuck with me for so long about healthcare decision making.
Yeah.
Am I doing something stupid right now that's going to cost me a lot of money? Usually when you attach a price tag to something, people think.
You're right. And that's usually the discussion I have. Like, listen, in the short term, I want you to think about this because of the long-term issues. And it's interesting because I think that the fat transfer to the breast has picked up a little bit, right? Because of some concerns of implants, whether that be the extremely rare concern with textured implants about ALCL. They've also identified about 14 or 16 people in the world that they found a skin cancer on the inside of their breast implant pocket. In the world, about 1 million augmentations are done. So that's a very small number comparatively. And then there's this whole nebulous of breast implant illness, which scientifically has never been shown to have any definition. And so people look at it and they say, well, I'm worried about that. I don't want to necessarily get these symptoms of, sort of feeling weak and fatigue or these sort of generic symptoms that get thrown on breast implant illness. And okay, I get that. And then they think, well, so I'm just going to do fat transfer of the breast instead. And my conversation there is, hold on, stop. Think about what you're saying. You're saying that a very high concern, which is breast cancer in women, 1 out of 8. So it's very, very high. We're going to do something today that is going to force you to have certain types of screening in the future on something that we know is very high. Or we can do an implant augmentation. If you get these feelings of fatigue or tiredness or sort of these generic terms, the answer is you take out the implant. And then that's it. I mean, to me, I just think when you frame that discussion a little differently, I think, I don't know that's your best option. I mean, that's your best option. No. Cancer reconstructions, they're little touch-up areas, etc. That's a different story. But I think the primary complete breast augmentation with fat transfer, that's something that you need to do your homework on.
Mm-hmm. You move fat to many other parts of the body. In fact, you're well known for moving fat to the rear.
Yes.
And that was kind of how you got started, wasn't it?
It is, actually. Yeah, we're here in a Real Self booth. So actually it was Real Self that actually really helped us get started. And it was because I had interest in liposuction fat transfer. I had previously done some fellowships with fat transfer to the breast for reconstructive purposes. And we realized that there was just a need in our area that was not being met. And that's really how I think that it helped us to get started. I think that there's a wonderful topic about lipo-fat transfers to the buttocks or BBLs, Brazilian butt lifts, and there's been such a tremendous evolution in it. I think fat transfers to the buttocks really took off because in the beginning, fat was being placed intramuscularly, right? And that's obviously unsafe. It's not being done. The risks are fat embolisms, et cetera. But what that allowed was it allowed your butt muscle to get bigger, which negated the need for butt implants. And so I think a lot of people in our community really latched on that. Like, well, we don't need to do butt implants. It's just butt implants have a much longer recovery healing process because it's very easy to stay off your breast. When you get breast implants, it's not as easy to stay off your butt when you have butt implants in the beginning. And so I think that the community really loved that and identified with that. And then that moved on to the patient community because the recovery was easier, the experience was easier, and honestly, the results were as good. So you fast forward years later, people recognize that injecting fat into the buttocks muscle is not safe because of the risks of fat embolism. So the struggle has been, well, how can you create this sort of muscularly athletic shape when we're injecting above the muscle? And so I think that we're seeing a little bit of a evolution where butt implants are starting to get reintroduced back in. I think you're seeing more and more people doing it. I think that's a direct result of that. I think there's been an overall change of what people like too, right? I mean, previously conversations were not focused so much on, hey, what's the sculpting? How does the body look? What's the shape here? The conversation is focused on how big could you get my butt? Now, that honestly, that was never really our practice. So I think we kind of always focus more on the sculpting or the contouring aspect of it. But in general, now when you have people come in, the conversation, the questions go directly towards, hey, I want to get sculpted. I want to have just a little bit more fit, a little bit more athletic, or a little bit more youthful. Because once you lose volume to that buttocks, it just makes it look older. And then you collect fat in different locations that just kind of make it look square and just not as youthful. And that's, I think, what people want now in general. I think that the size of people's butts was getting extreme, right? Mm-hmm. And it's always good to see things kind of come back into the midline. And I think that's where we are. So I think that's a great time. I think a lot of people are sort of focused on hourglass curvature, which has been around, I think, as long as time has. So yeah. I think that's great when society deems something as attractive and it coincides with something that's been consistent throughout time. I think that's usually a good thing.
Are you seeing more people near you who are losing a lot of weight from the Ozempic or this semaglutide shot?
Yes. So the secretagogues or the secretides are starting to revolutionize things that people can do, right? And of course they would. If you're saying, hey, we can see significant weight loss from this, and you were maybe a person who was looking at things like physically undergoing surgery, you absolutely would try that, right? It's slated to be the #1 prescribed drug ever in the history. That's wild, right? So from our plastic surgeon standpoint, the number of people that we're seeing on it, it's huge, right? I think it's been interesting for all of us as a community, because this happened since November, since like last year. All of a sudden it got traction and it has taken off. So as a community, as physicians too, we're all sort of like really on the front end trying to say, okay, how do we integrate this? How do we do things? And it brings up some good, important points. You know, the drug itself stops you making you hungry. Like it's just, you're not hungry, you don't eat. So that has real world implications, because from a surgical standpoint, I need you to get a certain number of proteins and nutrients and things, because we need you to heal. And we've long known that if we don't get the right nutrients, you won't heal. I mean, honestly, the pirates knew it, hence scurvy. I mean, because literally their gums would start bleeding if they didn't get the right nutrients. And for us, from surgeons, if we do surgery on you and you don't have the proper nutrition, you won't heal. So
don't be a pirate.
That's right. So it's made an interesting thing as far as, well, when can we safely start doing surgery after you have been off this medication, or if you're on this medication, we need to make sure that we're checking things. I think the other portion of it too is, you know, people don't always think of that as a medication. When you ask them, hey, are you on any medications or for any medical problems? It's weird, but a lot of patients sort of think, well, I just take this as a cosmetic.
I'm not sick.
Yeah, right? And so you would not even think then to need to do, because you would be like, oh, this is just a normal individual, like that we need to run a bunch of nutrition lab panels on you. So it's even become interesting in that standpoint that we have now started, and we're going to go back, you know, and really start like making sure that we actually outline these questions. Hey, are you taking these weight loss medications? And then the other thing is the medication works by basically keeping you full, right? So that's called delayed gastric emptying. And so when you undergo surgery, you're told don't eat or drink anything after midnight. And the reason for that is because we don't want your stomach to be full when you come in, because it could risk a aspiration event when you're in surgery.
Right.
And does that now change some of when we need to tell you not to eat or drink?
It could be 24 hours or longer.
That's right. Yeah. But we wouldn't know to tell you that if we weren't told about the medication. So I think it's a really exciting time that you have now a non-surgical option for people to help with weight loss. I think it's from a plastic surgeon standpoint, I think it's in actually any surgeon standpoint, it's an interesting time trying to figure out, okay, how do we integrate this into practice? When do we start offering people the surgery? We need to make sure that we're adequately screening for it, et cetera.
Yeah.
Yeah.
But I hadn't thought of any of that. That's very useful.
Right. I think it's a neat time from the standpoint of we also have options now that we can discuss, because sometimes, patients find you in different ways. And sometimes patients are struggling with weight. And so they come to you because they want to get like liposuction. And we see them and we just say, listen, you're not a candidate for liposuction. We need to address some lifestyle issues first before we're a candidate for liposuction. Because at certain BMIs, we just see increased risk of complications. And you see things that just aren't safe, right? And it's nice now to say, hey, listen, we actually have some options. We're happy to discuss these things with you, that this may be something that you want to do. I think that's great, right? I mean, I think that's great that you can get somebody in, you can provide them with some other options, and then once they lose weight, and they may or may not need to go get plastic surgery, right? They may not want to, but if they do, then we can move forward and discuss, okay, surgical options that you have.
I think there's another angle too here, which is when you're someone who needs to lose weight.
Yes.
You sort of make that your only thing, and everything else is number 2, 3, 4, 5, 6. So you might say to yourself, I would love to get my chin lipoed, but I really need to lose weight first, so I'm going to wait. Yeah. And so you end up waiting your whole life. And really what happens is you're not happy, or you're not as happy as you could be, because you keep delaying things that would make you happier or feel better about yourself, because you're always trying to lose weight first.
Yeah, I never thought about that. It's a really interesting take and topic.
Yeah. It's life-changing.
Yes, and I think even from the standpoint of, if I was slated to undergo bariatric surgery or the weight loss surgery, right? And I'm in it today. I'm here today. And I hear that there's a medication that may improve my weight loss, and you're telling me I don't need to undergo all surgeries have risks and complications. I can decrease some of these risks and complications. The medications have risks and complications too, but just, I mean, as a surgeon, I would move towards the medical option rather than
have we ruined bariatric surgery?
This is sort of, I don't think so. I think what you're going to find is that's going to be the trial of the medication, get you down a certain weight. I imagine then they're going to taper people off, and they're going to see if people can maintain that. And I think you'll basically have some people that don't, and I think those people are going to move forward with surgery. I think on the flip side, you'll have people say, like, I'm just not really interested in having to take a shot per week, or now they actually have a pill that's a daily pill. I think you'll have those people say, I don't want to do that. So I don't know.
It's going to be interesting.
It's one of these sort of strange things where when you stop and think about that first statistic we talked about, which is going to be the most prescribed drug ever in the history of medications, that is crazy.
So we were really here talking about you.
Yes.
But these are really interesting and important topics for people who are kind of... Are you offering the skinny shot at your office?
We are. We're going to start. We're giving medication. We've released a couple videos on Instagram and TikTok, and actually the response, hundreds of thousands of people, views, et cetera, and people are calling our office significantly. We said, okay. We did actually, I think, a really interesting video, which is where we talked about, because I think there's so much confusion, because there's like 4 different names of these medications, right? Yeah. And I think it gets really confusing. So we sort of basically treat it out so people can sort of understand that there's really only 2 medications, and they've just started branding the same medication in different ways, and it gets confusing. But yeah, once we did that, we realized that there was a huge sort of need, and we wanted to spend some time sort of really working on how we're going to integrate this in, how we're going to do it in a way that's both a positive experience and safe. Obviously, safety is number 1.
Always. And then you're going to find people who are coming back every month to see you, and they're going to be asking for other things like, what do you have for skincare? What do you have for, can I get my Botox here? So
that's right. And I think from a standpoint too, there's going to be a lot of just discussions of what are you going to do with this, depending on that weight loss. Even if you lose, it may not be 100 pounds, but let's say if you lose 30, 40 pounds, there's going to be some skin lax, the issues where you say, hey, what can we do to tighten this up? What are my options from non-invasive at the med spa all the way to surgical? So it's really cool.
What I love about it the most is it's going to let you build relationships with people in a different way that you didn't have available to you before.
None of us did, right? The answer was just, which we try to do, we just say, hey, listen, we need to work on some diet and exercise. I'm happy to recommend some fitness, people that we know.
And then you never see them again.
Come back to us when you're ready. But it's neat that we can, for those people that want, that we can actually then start to build a program within our office that starts to go. Because prior to this, the other sort of not a knock against the other weight loss programs, but essentially the other weight loss programs where they are giving you some versions of basically like an amphetamine, a legal amphetamine, which basically just kind of makes you like you're on an amphetamine and burning the energy. And that didn't really ever appeal to me. I didn't want to, that wasn't for me. But this option seems a little bit better. It's what a neat, simplistic way of just, it keeps the food in your stomach longer, so you just feel full. You're not actually hungry. And wild.
Beautiful. What do you want patients to know about you before they come to see you?
Our main focus, or our focus always has been, I think, or has really been since about 2016, which is just, we say a couple things. We empower expression. We help to achieve your goals. Our focus is ultimately trying to, just improve, get you to a point where you're happier, and also trying to educate you along the way. And I think we do a good job at all those things. So, and that's sort of the discussion too, I think, what we had with the fat transfer, right? Just that's what we want to do. We want whatever your goals are, tell us. Let's discuss your options, what you want done, and let's do it. So the way that we typically do it the most is liposuction, fat transfer. We do a lot of sort of higher definitions, all the way to what I call lower definition, softer sculpting, and body contouring, tummy tucks, breast dogs. I think that whole package, we focus a lot on balancing the body, which I think is really the take home. You want a balanced body.
Where can people find you online if they're interested in seeing you in person?
That's right. So on Instagram and TikTok, we are at SoCal Plastic Surgeon. We do some Snapchats where we're just sort of putting things before and afters, things that I think are a little bit, that are not allowed as much on Instagram and TikTok, and that's at Butts by Design. Our website is Butts by Design. Our office is located in Newport Beach and Upland, California.
Thank you, Dr. Nykiel.
Hey, it's always great to see you. And I can't believe it's been 3 years.
I know. If you're considering making an appointment or are on your way to meet this doctor, be sure to let them know you heard them on the Meet the Doctor podcast. Check the show notes for links, including the doctor's website and Instagram, to learn more. Are you a doctor, or do you know a doctor who'd like to be on the Meet the Doctor podcast? Book your free recording session at meetthedoctorpodcast.com. Meet the Doctor is made with love in Austin, Texas, and is a production of The Axis, TheAxis.io.